My producer, we have an editor who usually cuts this extra video out that where I'm about to give me talk, but my producer, we have an editor who usually cuts this. All right, folks, if you are watching on YouTube, you're in the green room with our guests. We're about to go live in front of a studio audience in about 10 seconds. Just bear with us. All right, I am going to just take a look. Just so everyone knows, if Mike doesn't join us, Amanda, I will start with you. But I have about 5 minutes of opening remarks that should give him enough time to be there. But just know that I'll skip around if Mike can't be here. All right, have a great show. Have fun. Thanks again for doing this. Super excited. Here we go. Greetings, everyone, and welcome back to Bright Spots in Healthcare. This is Eric Laser, and this show is being produced by Bright Spots Ventures. Bright Spots Ventures is dedicated to accelerating innovation through content, communities, and building meaningful connections. Our mission is simple: to spotlight what's working in healthcare and help scale it. We bring together leaders from health plans, hospitals, and other incredible healthcare organizations around the land to share proven strategies, bright spots to drive measurable impact. Through this podcast, our executive councils, our private events, and our go-to-market strategy work, we help surface and amplify the bright spots in our industry, these proven innovations that could be right under your nose that others can learn from and replicate to solve some of our biggest challenges in our industry. At our core, we're here to foster trusted relationships that fuel real progress in healthcare. We believe this is the best way to improve healthcare for all of us. We live by the motto, find a bright spot and clone it. If you have not subscribed to our podcast, what are you waiting for? Stop what you're doing right now. Type in bright spots in healthcare wherever you listen to podcasts, or go to your YouTube channel, or go to our YouTube channel, and you can subscribe to the video version of it as well. We want you to have access to all of these great, incredible thought leaders that will be sharing ideas, insights, and proven strategies that are working so that it could change your thinking. And maybe you could replicate some of them at your organization. We are super excited to cover this topic today around closing gaps at scale through equitable access, through smart remote virtual care. Our sponsor and partner today is one of our longest standing partners. The organization is called TytoCare. They were created to help families around the globe who are faced with challenges of accessing primary care get to providers. They work with health systems and provider groups to increase access to remote care and improve quality and performance indicators. They also work with health plans to reduce cost of care as well and improve the member experience. If you want to check them out, you could go to tytocare.com, TYTOCARE, that's one word.com. I'll tell you a little bit more about them later on during this episode. All right, we're going to explore now how leading provider organizations are using smart, remote, hybrid primary care models to close equity gaps and deliver high-touch, personalized care to members and patients who need it most. We're going to talk about telehealth. We're going to talk about predictive modeling. We're going to talk about benefit design and clinical design in a way that's going to hopefully enlighten you to like the next phase of virtual care. We're going to uncover scalable strategies that are transforming across outcomes and engagement across your populations. And we've organized the episode into 3 segments. First, how to expand access to the underserved communities. Second, we're going to talk about design, virtual first, not virtual only models. And then we're going to talk about closing gaps for more complex specialty, high need patients. Ready to go? And we got Dr. Michael Quee here, last to arrive, but first to be asked a question. So appreciate you being here. I'm going to introduce our guests as I bring them on to the episode today. We are jam-packed, so I'm trying to save time here. If you want to check out their full bios, we'll post those both in the show notes and if you're watching live on Zoom in the chat. Our first guest is Dr. Michael Quee. He is the Associate Chief Medical Informatics Officer and the founder and medical director of Rush Connect Primary Care. He's the Associate Division Chief for Clinical Innovation at Rush University Medical Center in the great city of Chicago, where I'm heading in just about a week. So lock your doors if you live there. I'll be in town. Dr. Quee, welcome. Let's start. What specific access or equity challenges were you trying to solve when you were launching virtual primary care? And then let's talk about how you thought about designing a solution that was both scalable, right, but also financially sustainable.
Absolutely. So thank you guys so much for having me here. Let me know if I have any audio issues. And
Sound great.
Perfect. Let's kind of take this right from the top. So the first one is, specific access challenges. I think in the Chicagoland area, we're blessed with a lot of academic medical centers. So patients have a lot of choices. Unfortunately, we have a lot of people too. And so there's just not enough primary care doctors to see every single patient in this great city of Chicago. And the worst care, I think, is no care. There's nothing worse for a patient than who can't access, care for knowing what diseases they have, getting medication refills, all of these things. And so we wanted to build a new way of delivering primary care that can start holding on to more patients or taking care of more patients than a traditional primary care model. So that's the first goal. Second part in equity is that not all of us are privileged to have, a lot of the privileges that we have here. And not all of us have jobs that allow us to take time off, allow us to, spend hours at the doctor to kind of navigate all of these things. And so we also wanted a system or a model that was flexible enough to accommodate all of the different busy lives and different circumstances of our patients. And so what we have then, created then is this virtual first hybrid type of primary care where the team sees around 30 to 40% of our patients in person. So it's not virtual only, just because you do need to see patients in person sometimes, listen to their lungs, listen to their heart. And some patients also do just prefer having a physical in-person presence that they can reach out to and see whenever they need. So again, virtual first, not virtual only. And then all the virtual options to make it seamlessly fit into our patients' lives, where you have a busy person who might be a fast food worker on their lunch break. They can see their doctor, we can adjust their medication, we can make all of these changes. And so first one is just designing the model in a way that fits around our patients' lives. And the second thing is we wanted to design a model that fit around our staff lives. I know that all the healthcare, people in the healthcare space, we are acutely aware of our staffing shortages. We have medical assistant shortages, RN, doctors, basically shortages all around. So we needed a model that is sustainable from a work-life balance for our peers. We're seeing our colleagues in the tech industry have this remote hybrid work. They're having better work-life balance, but we're not really getting that as frontline healthcare professionals. And so we wanted a model that could help accommodate that as well. And that is where the hybrid model also helps our staff from a staff satisfaction as well as a well-being. We get way more applicants for our positions than our traditional primary care models. And so it seems to have been borne out in just what our clinicians and other staff are looking for from a job perspective. And then the third piece is financial sustainability. We needed to design a model that allows us to see patients quickly, because the more patients we can see, not only is better for us from a financial sustainability, but it also goes back to my first talking point of access. The more patients we can see, the more care that we're able to deliver. And a couple of things that we do to allow us to have a faster visit is that we have a survey that we give out ahead of time to our patients. This is their history that we would otherwise spend our providers' time gathering. So this allows us to be faster during our in-person visits and our virtual visits, where our patients don't feel like they're rushed because we're still thorough. We have all the information gathered, and the doctors can spend their time synthesizing information, counseling, doing diagnosing instead of using information gathering. We've also have 7 people in our pod. So we are in a pod structure. It is an MD and APP. We need 2 providers in a pod, because if you just have one provider, that person is the only one that can prescribe. And that makes things very difficult from a turnaround time for patients. And then we have a medical assistant, an RN, a social worker, a clinic coordinator, and also a pharmacist. So this is a very heavily staffed model. We standardize everything across the board, from how we document to our visit lengths, to which days we're in person, which days we're virtual. Our clinic, our first pod, we are in person person for about 11 hours on Monday, and we're virtual on Tuesday through Thursday. So not only do we have more virtual options, our staff are working a 4-day work week, which they have found, to be very satisfying and has been really helpful from a work-life balance there as well.
And what about
And then
Friday? What about Friday?
so Friday, we're not there. But just like on the weekends, we have an on-call system. Patients are allowed to kind of page us if there's anything urgent that's needed. I've been on call every other week for the last year and a half, and I can count on one hand the amount of pages that we get. Because the way that the system is designed is that the APP and the MD have a similar scheduling format on the virtual days where every other hour it's open. Because every other hour is open, they can overbook patients. So my high acuity patients, I can see, weekly for many, many weeks at a time until we get everything under control. But it also gives us eyeballs on our in-basket messaging. And so by the end of the day, all our messages are clear. So we're able to respond to our patients within hours if they have any needs. So we're not leaving refills left unchecked. We're not leaving patients' concerns left unchecked. So all of these pieces kind of work together to allow us to create a model that is able to meet our patients where they are. If they want to talk with us virtually, if they want to message us, we can respond quickly. If they want to see us in person, we can do that as well. Structured in a way where we have a whole team that can support all of our workflows. And with all of our standardization, we are diverting things to the right team member so the patient gets the right person to deliver the right care at the right time.
I love it. I'm going to come back to you in a little bit. I want to dive more into this. And like I said to you when we were prepping, I think this is a full episode. I'll say this just for some commentary, and it's someone that spent 13 years in a leadership role at Teladoc. This is one of the most innovative primary care models that I've heard put in place that I think checks a lot of the boxes. So I'm looking forward to coming back to you and talking a little bit more. Let's move to a new city. Let's move to the city that I met my wife in. So an awesome city, the city, New York City. No offense to anyone else living in other cities. I'm from Boston, but there's only one city. So Dr. Amanda Parsons, she's the Vice President of Clinical Management at Health First. And Dr. Parsons, how are you guys thinking about delivering individualized, personalized care for higher need members, right? You work with a lot of Medicaid and duals, whether it be in a hybrid or remote environment. And what are some of like maybe the virtual components that have been proven effective for maintaining engagement and outcomes for these hard to reach individuals?
So thank you for that question. So at Health First, we deeply value the physician patient relationship or the clinician patient relationship. And we view our role as a health plan to support and nurture and help nurture that relationship and act as in between care, between appointments. And so we see digital or virtual care as a very strong complement to the face-to-face visit. And we are really excited about all the different applications that we can use it in. As one example, we have a high-risk maternity team. We use a predictive algorithm to figure out who is at a higher risk of a poor outcome, be that a NICU birth, a low birth weight baby, or other complications of maternity, and then we engage with those members and supplement that the care management engagement with digital tools. For a long time, we used Text for Baby, which was like the free national personalized texting campaign. There are others now that we've pivoted to, but we love these kinds of solutions because it allows, just like Michael was mentioning, it allows patients to access information when they want at their fingertips. They can also they enter their due date. They can enter in their appointments, and there's these reminders, these little nudges that can help the patients keep track of all as you guys know, there's a lot of appointments in maternity care, especially if you're a high risk maternity case. And so it's very helpful to have like personalized reminders, like tailored to your specific situation, and then offer up a lot of information at your fingertips. It could be at 3 o'clock in the morning that you have a question or that you're feeling something, and we really want to make sure that we show up for our members, whenever they need that help. And so those carefully curated, evidence-based digital tools are so key to being able to fill in that in between uh, care. And then, like I said, our care managers work really, really closely. We want to be so strongly and tightly aligned with whatever the care plan is for that member and help, shepherd people back to the care that they need. We also leverage digital or virtual like doulas and other types of providers as part of the maternity episode. And so we're really excited about these kinds of programs that can be brought to bear that go beyond the traditional like in-person appointment, but importantly that don't replace, it's not like digital only as was mentioned. That's super important, that this is a complement to a rich relationship that a patient has with their clinicians.
I like it. So it's also hybrid. You're using the tech, you're enabling humans through the technology to be better at communicating, and also primary care, but also much more higher risk primary care when we're talking with expectant moms. Do you have any kind of results, whether it be engagement or any, I'm not sure like how long this has been going on. Like, do you have anything to brag about that's working right now?
So I would say, well, we're very excited that our high risk maternity program has led to decreased NICU births, decreased like preterm births. We don't ever think that it's like a single thing, it's not like just like a soccer game. There's not like one player that was like you solely responsible for the goal, right? Then there's a lot of things that go into it. We really practice whole person care. So we're addressing things like social determinants of health. We're layering on there's like these digital tools, these other types of providers. And so really what we keep our eye focused on is, does it matter to the member? Have we changed the ultimate outcome with this constellation of services? So yes, we can reduce NICU births. Yes, we can reduce preterm births. Those are really the outcomes that we stay very, very focused on. And so we don't always know like what part of the secret sauce is the most responsible for it, but we know that all of those that these tools are part of the secret sauce.
Great. Love it. We're gonna just folks, just so you know, we're gonna be really tight on time today. I'm gonna try to jump around and keep us on time. We'll have some of our panelists do their best to answer some of your questions in the Q&A module via text and writing, as we've been doing, and we're gonna keep on moving along. So our next guest is Dr. Gabriela Lawrence. She is the Senior Director of Clinical Solutions at Care. And Gabriela, what are some of the we just came from an urban kind of setting. What are some of now the unique challenges that arise when delivering care in other underserved communities, rural communities? I guess it could be urban too. And how are you seeing the technology bridge those gaps with all the different organizations you get to work with? You are on mute.
I am on mute. This is
Okay, it
always
happens.
my weak spot.
It happens once a show. It's usually me.
All right, fine. I feel better about it. Well, as I was saying, great question, Eric. I think we understand, right? There are countless challenges that arise, particularly around care access and quality care in underserved and rural communities, right? These are communities that have limited resources. Travel to providers is a huge burden. Quality care is simply lacking typically in these environments. And the implications of that lack of care access, it's not just limited to, poor health outcomes or quality of life implications. The impacts are really far-reaching, right? We've got overburdened systems, we've got unnecessary high cost utilization, and it goes all the way to things like absenteeism in schools. And I'm going to focus on that for a little bit. So I think the best way for me to address this question is actually to talk about a particular example of an organization that we worked with. So we partnered with Cone Health in Guilford County, North Carolina. Guilford County has a very large immigrant population. It faces very high poverty rates, and the absenteeism rates in schools there is astronomical. 1 in 4 students in Title I schools, of which there are many in Guilford County, are absent 20 or more days, which is, of course, it's extremely disruptive to the kids, to their families, detrimental for the education system. And oftentimes it's minor issues. They can't, school nurse, if there is one, can't prescribe even a Tylenol without a physician involved. And on top of that, 40% of only 40% of schools have school nurses on premises. So these kids get sent home, and now they're home and in a community where there's limited clinician shortages, difficulty accessing care, and so they end up in the ER for their treatment. And so telehealth is a great solution, but the challenges from a telehealth perspective is often that there's lack of trust, language barriers, limited infrastructure, to really enable that quality care. So when we partnered with Cone Health, and we are really, I would say, championed by Dr. John Jenkins, the goal was really to find a way to provide effective quality care. Care that was really equivalent to what the kids are going to get when they walk into a primary care physician's office. And we do this in trusted locations like schools or community centers so that kids can get that easy access to primary care, but they have the ability to do a full physical exam remotely. Cone was really, and it continues to be, an incredible partner. When they embedded TytoCare into their school health programs, they immediately understood that it was critical to bring in trained facilitators, what they call telepresenters, to get these children onboarded into the system, really facilitate the trust, handle language barriers during the visit, and actually be the ones to perform the physical exams, but then they have to seamlessly connect the parents, the kid, the physician's office, and the clinician themselves, and enable clinical, real effective remote care. So it was a pretty incredible partnership with really incredible results.
Love it. That's great. Incidentally, I've been taking notes. I took some notes in preparation for this, folks. If you want a copy of my notes, I'm a B plus, A minus note taker. I think I'm still better than AI. I'm going to ask you a favor of taking our feedback form, our feedback survey that will be distributed to you via email in about 25 minutes, but also distributed through chat right now. This will allow all of you attending live to guide us so we could continue to create a better experience for all of you through content and the flow of the show. And to that end, one of the things that was suggested to us about 4 months ago that we try to do is make it easier for you to come back and attend another live event. So we put up a poll of our upcoming shows, and the ones that you want to attend, we're going to register for you. So you don't have to, use those precious fingers of yours to click and register again. So we have an upcoming episode, a special one on Tuesday, typically not on, usually we're on Thursdays. We're going to talk about the new growth playbook in this new era of healthcare and how to build relationships and trust in healthcare. I'll be facilitating that with 4 incredible commercial leaders across the industry. And then we're going to cover one around medication adherence on August 7th, around star ratings, and then one around engagement and what risk models are blind to around engagement. And that'll be a fun episode as well. We have some incredible guests already lined up for each one of those episodes. So if you're attending live and you want us to sign you up, we're going to put up a poll for you right now. Okay, let me bring in Emily Young. She's the president of Tufts Medicine Integrated Network, part of Tufts Medicine here in my hometown of Boston. Emily, in this new era of healthcare, innovation's never going to be more important, right? We have to play the hand that's been dealt to us. How is Tufts' approach to innovation, and maybe share an example of how you've successfully leveraged this process to identify and solve a pressing need here in the greater Boston, Massachusetts area?
Thanks, Eric. So we've approached innovation not as a big project that's happening outside of the care teams, but really by engaging people, engaging the front line, and how could you do your job better? How could you just do a few things to do what you do better? So in 2019, before COVID, we made an intentional decision to bring a group of physicians together. We actually named them the Scalable group, charged them with come up with something innovative to accelerate progress. And we made the commitment You guys pick something, we will spend 90 days and we'll come up with a minimally viable product. And at the end of 90 days, if we don't have it, we put it aside and we move on to something else. But let's either declare success or not in 90 days. And we asked them we said, pick whatever you want. So often we spend our time on the pop health side of the house, focusing on the plan requirements, the HEDIS requirements, things we're doing to you, and said, you guys tell us what you want to work on. So they came back and they picked behavioral health. And we were like, okay, you thought you guys might pick something easy. But they said it was the one thing that if we could do something to help with just an unmet need for behavioral health, everything would be better. The office would run better. Probably the most compelling or the comment that resonated with me the most was, I will go home at night and sleep because I will know my patients were given services. And without this, I'm more, I just don't have closure to my day. So to do something in 90 days, we said, all right, we need to find a partner. We want to stand something up that's minimally viable. So we reached out, we found a partner to help stand up a virtual teletherapy solution. And we started small, not worrying about all the technology integration, just here's the product. Can we do very simple text-based referrals, get something up and running and see if it's successful? And it was very successful. The PCPs adopted it, patients used it. What we really saw was significant adoption. I think at, between 60 to 80% of patients being referred, depending on the office, utilize the service. And physicians described it as, I used to give someone a piece of paper and say, good luck trying to find someone. Hopefully someone answers the phone. Hopefully they accept your insurance. This was a payer blind solution that the providers could give to all patients. So it worked. And then what we did over a period of time was rolled it out over the whole network. Obviously, we embedded it in Epic, got the technical connection so you weren't, texting. But we are here a few years later, and we've just seen stunning success. Over the past 12 months, we've done about 65,000 sessions. We see about 5,000 to 6,000 new sessions a month, and it's a rolling group of new patients. It's not the same patients being seen over and over. We saw a 25% improvement in the average PHQ and GAD scores from the T0, that first assessment, through T2, which is typically 8 sessions. 25% of the patients with severe depression are now in normal functioning state, and 63% of those with severe anxiety have moved into the normal functioning state. And one of the most interesting things we've started to look at, and this is not scientific, it's not a controlled study, but we've started to look at, of the patients that were referred, for the patients that accepted the help and are engaged with the solution versus those who didn't. What does emergency room utilization look like? What does inpatient utilization look like? And we see that the group engaging has lower utilization. Well, then we said, well, it's probably they don't have comorbidity, but we've started to look at COPD, diabetes, and what we're seeing is what the research would show, that, even by condition, there's less utilization with the group that is engaging with the service. So we're very excited, but it also has shown us that integration, we can be an integrated platform where we can bring virtual into our ecosystem, and we see great adoption and see it. This was the success that has let us venture into some other things.
That is staggering. So you're taking basically a collaborative care model, like from the AIMS kind of model, but you're not exactly, and you're bringing in virtual behavioral health into this practice. And I just want to make sure I get some of these numbers right. 65,000 or so total sessions at a pace of about 6,000 visits a month. And you said 25% improvement PHQ-9 GAD-7, 25% of severe folks diagnosed with severe depression back to normal, 63% of folks with severe anxiety back to normal.
Yeah.
That's unbelievable. Love it.
Yeah.
Love it. All right. I want to shift now. Let's shift over to like a virtual first, not virtual only kind of segment here. And I'm going to bring back Michael Quee. He is the inaugural medical director at Rush Connect Primary Care, part of Rush University Medical Center. And Michael, using virtual first, not virtual only, can you take us through now how the model is executing on the ground? Like, what does a typical patient journey look like? What are some of the results? Kind of take us through sort of a day in the life of clinical operational and how the patients are satisfied. What are you seeing?
Awesome. So I'd like to kind of take it through from the patient's lens first. And then I got a question about like how do we deal with like rural patients who might have difficulty with telehealth. I love that. Let's use that patient as kind of our initial patient archetype. And so let's say we have like an old or like 78-year-old patient. He's had a transplant, he has heart failure, he has COPD, high blood pressure, diabetes, you name it, a million different things on their medical problem list. They decide to establish here with us. Immediately, right off the bat, they get a welcome packet that says, this is what this clinic is about. If they can utilize our MyChart and technical resources. If they can't, they don't get that, no problem. 2 or 3 days before the visit, my team realizes this patient hasn't filled out any of their questionnaire. We call to say, hey, this is what the clinic is about. Do you need help filling out the questionnaire via telephone? They say, nope, I'm good, I can do it. We say, great, we'll see you during our visit. They come in during our visit. They come in about, ideally 10, 15 minutes before. But if not, if they show up day of, we also see if they filled out their questionnaire. We do the check-in process. Patient has not filled out their questionnaire. Not a problem. My medical assistant will now do the questionnaire with them during their intake process. So by the time the patient reaches the provider, we've had multiple ways of getting this questionnaire filled out. I walk in the door as the provider. I only get 15 minutes per patient. And I say, hi, Mr. So-and-so. I see you're here for your high blood pressure, your diabetes, your heart failure, your COPD. You're having some ankle swelling. Oh, you're having this crushing chest pain, by the way. And I say, look, we only got 15 minutes. Thank you for filling these out in our questionnaire. Let's take the top 2 most important things for this time. And then I'm going to overbook my schedule in the next 2 days. So that way we can address some of these other concerns. This is made possible because of the every other hour open on our provider schedule. So I talk about this with the patient. I go over their crushing chest pain because that's probably the most important. I then make sure that they don't have like an active COPD or anything else because if your heart doesn't work, if you can't breathe, those are the things that are going to kill you immediately. We make sure that he's not in a COPD exacerbation. We do the EKG. We send them for troponins. We make the assessment of whether or not they need to go to the ER. All of that to kind of handle things initially for the patient. The patient goes home, they get a follow-up survey in a couple of days asking, hey, did your symptoms get better? Patient responds, no, things didn't go really well. That goes directly to our messaging pool. My nurse sees it, gives the patient a call, checks in, say, hey, like, how are things going? Patient says, oh, my chest pain is better, but now I'm having some breathing issues. My nurse does a triage and assessment and then gets the patient and messages the provider saying, hey, this patient's having some breathing issues. How do you want to handle this patient? The provider says, hey, I've got all these gaps in my schedule. Let's overbook, and then let's make sure we talk with this patient. And so we have the visit with the patient then. Let's say 3 weeks go by and the patient's, saying, hey, look, I can't deal with all of these, virtual options. That's not a problem. We do telephone visits as well. This patient has already demonstrated to us they can come in person. And so if we really need to, we'll bring them into the clinic. But so much of primary care can be done through telephone. And so when our schedulers are making the appointments with our patients, communicating with them, they're given the option of both virtual and telephone. I think the visual is very important from a rapport building, but visually, I don't really need to see a lot of things in primary care. I think as long as I'm getting the symptoms, communicating with the patients, we're able to move our patient care forward. And so there are a group of my patients who are part of this practice who cannot use any of our digital technology. They never do video visits, but because I can talk with them every day, basically every day of the week if we wanted, but weekly for 2 or 3 months, we have gotten their critical diseases under control, and now they're spaced out to a 3-month cadence, 6-month cadence, 1-year cadence with us. That makes it much easier for us to manage their conditions. And so a few things of our day in the life that makes this work. One is the highly structured schedule. The providers don't get a choice. You don't get a choice of just blocking your schedule for 4 hours where you're only seeing patients and then 4 hours of not seeing patients. We have that every other schedule. So that way our eyeball's always on the in-basket messages. So we can always handle messages that our patients have. That's also why we have 2 providers. That way every other hour can be open. Their message in baskets are linked. So that way we can always respond to patients as quickly as possible. I didn't get a chance to talk about how we document, but we document directly in Epic in the problem list. And so all of our documentation is very discrete. We have a template that we enforce our providers use for at least 2 medical problems per visit. Afterwards, you can kind of document freehand however you want. But in our documentation template, we say, are we putting the patient on a pathway? What are our patient's goals? What is our plan? What is our background? We even pull in lab values in there. So that way for diabetes, I can immediately see all of their A1Cs, their creatinine, and all of the necessary numbers right then and there without having to hunt and peck through the EHR system to find that information.
And
with that,
let me just poke at this because I think I remember the answer to this. You're not using ambient listening,
no.
and you're not using like any kind of like risk adjustment kind of AI like you're not using a lot of the AI technology yet. So like there's probably more efficiencies to squeeze out over the next 6, 12, 18 months.
Absolutely, exactly. And this is a little bit of a tangent, but when we utilize AI, it actually slowed us down because our notes are so templated, information's already there. So if I'm using AI, I have to review it. That's probably a separate thing, but there is definitely a way where AI can definitely turbocharge our clinicians and our team and allow us to take care of our patients even faster. Now, I know that I'm probably already overtime in my section, but just some measures for you guys, right? Our clinic is filled at 107%. And so we're not hurting for patients. Patients are, we're filling up every single one of our slots, including our virtual slots. On our in-person day, where we have a 12-hour in-person day and 11 hours of 15-minute patients, they're scheduled for 20-minute blocks. So that way we have a little bit of buffer, but our clinic ends on time every single day. We have not had a time where we stayed past 7 p.m. And so the last time you guys have been to a primary care doctor, just think how many times they were running on time. And this helps our patients because now they know if my appointment's at 2, I show up at around 1:50. I'll be probably seeing my doctor around 2, 2:02, 2:03. I'm out the door at 2:20, 2:15. I can go back on my day. I don't need to take a whole half day off of work. So from an equity perspective, it makes it better. And we've moved a lot of the work to the patient time. I've talked about this questionnaire ad nauseum. Like that's really where we're getting some of our efficiency is that we squeeze enough efficiency out of our providers. They're burning out. We squeeze a lot of efficiency out of our healthcare system. But I think something that's untapped is patient time, giving them the comfort of their home to really think things through, document their responses. I think it's also better from a patient as well. And then the patient types that we see around an absolute 20% more commercial patients in this model than our traditional practices, which you can guess these are younger, tech-savvier patients. But we also have our chronic patients who really like this, like that rural patient that I mentioned, who like this team approach, where there's a pharmacist reaching out, a social worker reaching out, and also the way that we document allows us to build care plans. So we can build chronic care management, we can build advanced primary care management, continuous glucose monitoring, all of these other things that allow our additional staff members to generate revenue to try to make this financially feasible model.
I'm going to bring you back in a little bit so we can talk about the coding and the financial part of this. But I want to keep us moving. Incidentally, folks, and if you could look at the Q&A module where Michael already answered this, his panel's currently 3,600, looking to get up to 5,000, could handle 10,000 with some technology. Emily, as you see these new, and Emily Young, President, Tufts Medicine Integrated Network, as these new care models emerge, how are you experimenting with virtual care to support, like similar to Rush, patients and these overworked clinicians?
Yeah, so many parallels, Michael, as I'm listening to you. Also that we here have a huge access problem. So access is part of what we're going at here. We really are working to integrate virtual into the traditional experience and not create that alternative, unconnected parallel path. We think that just adds cost and complexity to healthcare for the provider and the patient. And there's no shortage of virtual providers out there right now. There's lots of options, but today it really operates like, well, I'm here getting my virtual care. My brick and mortar knows nothing about it. And then maybe I, the patient, am going to tell the provider the prescriptions I'm taking or the problems I had, or it's just like urgent care. Now, here are all my problems. Virtual didn't work. Can you help me? Leaving the provider and the patient frustrated. So building off some of our success in behavioral health, we decided again to think about a partnership model, recognized our strength, and that building an app and providing 24/7 virtual service is not something that we can do right now, but how could we partner with someone? So we found some partners, one to help us with triage and one to help us with 24/7 real-time care, be it primary care, or be it urgent care, but 24/7 care to access a physician. We feel very, very strongly that we can't let the disruptors claim this space. Again, if we don't lean into this space and find this hybrid model, we're setting ourselves up to lose commercial lives. because I think there's cherry picking going on. A lot of these models aren't interested in the Medicaid lives, aren't interested in the Medicare lives. We want to have a model that we do for all patients, but we do believe the commercial patients will really lean into this. So started off with this question: how does virtual and how does a 24/7 partner help us with access? Every single day, we send tons of patients to the urgent care setting because we can't get them in, or they've actually started to just know that they can't get in with their primary care physician, so they're just starting to go to virtual. How could we save this? Every day, our clinician's schedule is booked with the patients that they probably don't need to be seeing because the acuity is very low. But the triage is just, it's who calls and what order you call is how the slots are filled. So the patients that really need to be seen more to prevent the emergency room visit, stop the disease from progressing, prevent that inpatient visit, they're the ones who might be going to the ED and then getting admitted versus they really could use that slot with their primary care physician. And so we started playing around with, if we bring a virtual provider in, is it okay if we start to pay less and you're paying less for that volume and you're seeing patients for low acuity and we're going to offload that to someone else. And then we see more patients. So started off slow, right? Because this, I think, is classic change management, and to some of the primary care physicians sounded terrifying, right? You're going to like eliminate patients from my schedule. So we started by just putting this out there in our app. We said, let's put this triage, and this will triage you to either go see your doctor or, hey, try this virtual solution. Let's put it on our app. Did that. I mean, we always joke about if you could find it, good luck. People did find it. They did use it. We saw that the world didn't end. Care was safe. Patients didn't complain. So then we said, let's lift that out of our app and let's put it directly on our website. So now you can go out to our website. You can do the triage. And again, the triage might lead you to book an appointment with your primary care physician. The triage might lead you to use this 24/7 option. And the triage might say, go to the ED or, check in a couple of days. We lifted it to the website, started to see a little more utilization. And where we are right now is building on that utilization and offering this to our employees, partly as they're struggling with access too, right? It doesn't matter if you work in the healthcare system. It's hard to be seen by primary care these days. Also from the cost component, I was just in a meeting earlier this morning about, well, we could save $1 million on our health plan benefits if we could convert X number of visits to urgent care to using this platform. So slowly building momentum that the world isn't ending. There's more and more options. You can use this. We did also, we're starting to now roll this out in primary care physicians, just like you refer someone to urgent care, refer them to the virtual partner. We sent out a mailer over the weekend, over the 4th of July weekend, to all the patients on a panel. That weekend alone saw 12 visits so we're slowly building up and seeing more and more visits. We're starting to tell the stories, a story of, a patient who needs to be seen on the weekend. Normally you might, for something mild like a rash, normally you have to call your physician the next day, take 2 hours out of work, go to your doctor's, pay the copay, park. Really, could we treat a rash over the phone? So patient does it, sends the pictures, half an hour, problem solved. Swimmers here on vacation. How are these things that could unclog our primary care model and let us have a seat at that virtual table?
Practice at the top of your license.
Yep.
So I'm going to jump around a little to try to get as much content in here as possible. Incidentally, folks, we'll come back to Dr. Quee to talk about sort of like a blueprint, but we talked about AI and some practices, even hybrids, don't have it yet. We are hosting a private roundtable around this topic of adopting AI into the health system coming up. And if you represent a hospital, health system, or medical group, and you're listening right now and you want to come to our August 13th private event, it's not being recorded. It's a peer-to-peer discussion I facilitate around AI adoption of value-based care. August 13th, 12 o'clock. We'll sign you up for that, but you have to be part of a hospital or health system or medical group. So I want to jump into some complex patients and bring in Dr. Gabriella Lawrence. And Gabriella, when you're thinking about how are you guys solving and shortening the gaps in care for hospitals and health systems, they're having problems with some of their most complex patients and using the technology to do that in a more effective way and getting better leverage from both advanced providers and primary care providers.
So this is a really great transition, right? We talked about schools and rural and all that, and now we've got like a totally different scenario and a great opportunity to talk about transitions of care, particularly in complex patients where high readmission rates are astronomical in some cases. And the thing that is sort of frustrating when you think about readmission rates in complex patients is a lot of times these are preventable. Right? We've got guidelines to help us understand how to handle patients post-discharge and help them transition to their home and not end up back in the hospital. Right? You've got some Coleman's 4 pillars, for example, where you have timely primary care or specialty care follow-up within a short period of time post-discharge, medication reconciliation and management, making sure the patient goes home knowing what their red flags are, so knowing when things are escalating and what to do about that, and that they have someone to turn to when there's an escalation, and teaching them about their personal health record. Those 4 steps are known to improve outcomes post-discharge. I'll say in the literature, you can see that visits alone in patients with heart failure can reduce readmission rates 20 to 30% if you get that visit in within 7 to 10 days post-discharge. So that step alone has a huge impact. But even when a patient is like ready and willing to go see their specialist or their provider, sometimes it's impossible to get an appointment, particularly with a cardiologist when you're a CHF patient, or even your PCP, right? Everyone here is talking about that, how overburdened the primary care departments are. And to get a visit with a cardiologist especially would be nearly impossible within 30 days post-discharge, let alone the 7 to 10 days. That is the, ideal window. So we work with some partners. Rochester Regional Health is a great example, to help them build post-discharge programs. Well, they really built the program. They just leveraged our technology. They leveraged TytoCare's technology and incorporated an amazing team of community health workers, RNs, LPNs, and APPs. And the first step was really connecting with the patient within 48 hours post-discharge. Like that was the most important thing. Once they did that, they then conducted home visits using the TytoCare device. The cadence kind of ranged, I would say, from once a week to once a month, depending on the severity of the patient. This was specifically in heart failure post-discharge patients. And they were able to send in community health workers. Sometimes also the nurses or APPs would go into the homes and actually capture data points, record heart sounds, record lung sounds, and send those back over to the physician who can listen and know what to do and give actual response, and they can do it asynchronously. So, you can do it timely, but you also don't need to have the physician available at that same moment. The lung sounds and the heart sounds can actually be recorded and sent over to the physician through our technology. In addition, the community health workers could also capture other vitals, store that as well in the app, and the clinician can then see those vitals as well to be able to make informed decisions. So it's really the ability to have like a full care team see a patient, but at a much lower cost with a higher impact and create more effective care. And then you can actually reduce these readmits, which we saw. We saw, great reductions in readmissions, ER visits, bed days, and the cherry on top is that you're also closing care gaps at the same time.
Right.
So.
And it's very similar to what Emily said. We're practicing at top of the license, where it's not exactly that, but a cardiologist needs to be, or a primary care cardiologist needs to be on the horn right away. We get them on the horn right away, but the data, because it's stored, you capture it from patient to cloud right away. That the cardiologist could, on a less severe, look at it at a little bit more relaxed time frame, so that the schedule could be maximized. It's really unique. Incidentally, we're going to get into sort of playbooks. I want to do one more complex example coming out of New York, but if one of the pieces that your team, Gabriella, sent me for prep for this lays out a blueprint on how to roll out a urgent, primary care remote program in a case study format. So it's around Baptist, I believe, if I remember correctly, Baptist Health, and it's a great from waiting room to virtual room blueprint and how to build it. And some of the results they received, they generated from it as well. It is title branded, but it is really educational. So if you want a copy of that, we'll put up a poll right now, and our team will get it to you. And it talks about in this case study how Baptist Health used TytoCare's ProSmart Clinic and combined it with Tyto's device that you heard Gabriella use. They're easy to use. It's an easy to use FDA cleared device that a non-clinician could use, and it's got AI powered guidance and diagnostic support that enables the data to go right directly to the provider. And so you could be doing a live visit with a PCP, or you could be doing something where, like in the Rochester example, where the specialist can look at the data later on in the day or the next day if it's not urgent, and it goes right up to the cloud. And an educated kind of caregiver all the way up to a school nurse or maybe a CHW could use this device very easily with the child in this case. In the Baptist case, I think it's with a school system, but anywhere. So it's really cool, and it's a really interesting case study if you want it. I'm going to move now back to New York, and Dr. Amanda Parsons, your team is dealing with like this broad member base across the state and focuses on not only the high needs, but the challenges with care coordination. So what are you using to proactively identify and engage members who might otherwise fall through the cracks?
So I love that question. I think one of the most underutilized tools is the caregiver in the context of the relationship. And I think that that's something, as you were describing, Michael, in 15 minutes, it's hard to even get at all the patient's questions, let alone what the caregiver's questions are. And we find our caregivers, they're often worried, they're overburdened. And, when we've identified somebody as a complex member, one of the first things we're doing now is figuring out who are the caregivers and how can we help support them? Because talking about working to the top of your license, caregivers are able to do a number of things. They help schedule appointments, they help shepherd appointments, they help remind about medications. But if we're not helping them navigate the system, as well as helping the member navigate the system, we're not fully deploying all of the solutions that are there. So we have a really nice relationship with Carol there. They help provide advocacy, one-on-one care advocacy to members and their caregivers. They have videos, they have support groups, different live events. And we find that is one way that we can address the members who have complex medical needs in our long-term care plans. And in addition to that, we spend a lot of time figuring out how we can connect with the providers around the members that have been surfaced as having lots of needs or being medically complex. Because a lot of times we're trying very hard to support the pathway, but in some cases we don't know what the pathway is. We don't know what the clinician is thinking. So we also deploy a lot of interdisciplinary rounds between our care managers and the providers to get on the same page. And then we can using that caregiver strategy, help make sure that the caregiver is on the same page so that everybody's like rowing in the same direction.
Love that. Another good use of just getting scale, right? I mentioned it with the Tyto example. I just think we have to enable or militarize all of us as caregivers to take better care of each other. And that's a really innovative way of doing it. I love that. I want to get into sort of just as we get to the close here at the top of the hour, we're going to summarize some of the sort of the blueprints. I like doing this towards the end of episodes. So I'm going to bring back in Dr. Michael Quee. And Michael, why don't we just, we're going to combine sort of the last two questions we planned. Like, let's talk about the 3 to 5 things that were absolutely paramount for the early success at your clinic, and how you would potentially, if you were launching another clinic similar in another city, how, if those were the things that you would start with.
Sure, absolutely. And so I think we'll start off with the people, process, technology. I think this framework that everyone is probably familiar with. And the technology probably isn't even the most important. I'll substitute it with financial. And so the people part, if you were to replicate this, a lot of this is contingent on the people that are in the system, the people in the pod. If you don't have an APP, you can't do the alternating schedule so that everything falls apart. If you don't have a social worker or a pharmacist kind of handling a lot of these things, it makes it harder for the providers to kind of just quickly delegate tasks to the rest of the team members. So you really need that team-based approach to care. I think the evidence on team-based approach, it's 20, 30, 40 years old. There's no question that team-based approach is helpful, but then it's the financial piece. How do you pay for all of this? And so the financial piece is really critical. Right now, we're operating in a mostly fee-for-service model here in the Chicago landscape, but I think this actually does better in a value-based care kind of environment as well. Then you are no longer looking at clinic volume. And a lot of that, what we were initially designed, that standardization, that second piece that is highly critical is the 15-minute visits, or they're scheduled for 20, but the patients get 15. And then all of the standardization is all around kind of how do we generate enough revenue to keep the clinic afloat. So the first two things is people. You need a team-based approach to care. You need an organization who has appetite to invest and fund 7 people for a pod. A traditional primary care model is 1 doc, 1 medical assistant, maybe a quarter RN. And so this is a heavily staffed model. So you need to be able to do that. Second piece is you need to be able to ensure the clinic stays afloat from a revenue perspective, whether it's clinic volumes or if there's value-based care contrast on quality. I think this model would do kind of quite well there. And then the third piece, and I'll do subsegments of this, is that standardization. So standardizing in multiple ways. So the first way, which I think none of us have quite talked about, is that patient education piece, moving things to patient time. I think that is still something that we're trying to work through. And I think an example that everyone can relate is, let's say, take Amazon. You can't peruse Amazon physically in person. They just don't allow that. You just have no way of possibly doing that. And so we do have patients who come to our model like, well, why are you guys only in person this day? I only want to be seen in person. Unfortunately, this model is not great for you then in that, right? We can't take care of everybody. And so I think being aware of what our standardization trade-offs are is critical. So first piece is patient education, make sure they understand, making sure that you as whoever wants to execute on this knows what patients you're recruiting, what patients you're avoiding, what are the trade-offs that you're making. And then on that flip side for standardization, it's also the standardization of the staff. Right. So standardization of the schedule, knowing that providers are going to be a little unhappy not being able to, hey, I want my schedule this way, my schedule that way, because traditionally that's the model that they have grown accustomed to. But this doesn't work if everybody has their own little fiefdom, doing things a little bit differently. The system works together like a nice intricate puzzle. You cannot have one piece that wants to do something differently. So with that, you need to make sure you're hiring the right types of people and you have a standard process for that. You have all the process standardized. We have things down to like the exact action my medical assistants are taking when they're rooming a patient. So like that's the level of granularity that I think you need. And then the last piece from a standardization is you really kind of need an organization's culture or kind of a militant person. I don't know if this is good or not. I mean, this is me who basically is like, this is the way, right? You have to use these care plans. You have to standardize this. Like, this is just the way it has to operate. And maybe we haven't figured everything out. We're still building this, ship as we're flying it. We can change. But if we do change, the whole model changes. And we're just opening up our second clinic in November. They're going to have different learnings. If they discover something that makes us more efficient, this original clinic is going to adopt it as well. So that's also another way of distributing learning. And then an eye towards the future is if you can standardize it, if you can write it out, that makes it right for AI to kind of start taking over tasks. So we're looking for in 2-3 years, once we kind of mapped out all of our processes, can we use AI to really turbocharge our clinical teams to go from 5,000 patient panels to 10,000 without, destroying that relationship that patients want with their providers? Because at some point, we don't think this is a transaction. We think this is a long-term relationship. These are just tools to help. And that relationship is really kind of paramount to primary care. So everything we're doing is really in service to that. So just kind of recap.
I was going to recap. Go ahead. If you want to recap.
Go ahead. I was going to say, just to recap the five things: people, make sure you can hire the whole team, making sure that you have a financial model to sustain this and for it to be afloat. Standardization kind of all the way across the board. Standardization in terms, especially for the provider, and like this is the way you all have to kind of do things that way. And the fifth part, standardization of patient education. Make sure the patients understand what they're signing up for. This is a highly rigid, standardized clinic. If you can use all the tools, you can have a great time. If not, this may not be the best model for you.
And we were talking like it's really Ray Kroc at McDonald's. I know it sounds crazy, but it's really that same methodology of standardizing processes, right? We were talking about that in our prep. Let's close things out here, and I know we're coming up against the hour here, and just look at the future and bring back Emily. Emily, like where do you see the future going, and what are you excited about as far as the next wave of virtual primary care?
Yeah, I think really leaning into this hybrid model and thinking about how do we find the sweet spot. I think, Michael, very much about what you're talking about. Ours will look a little different, but we're stepping into that space, really looking at how do we partner with health plans in this space. They do a lot of engaging virtual only models. And we're stepping into some of our first, like engage us, look at us first, looking at how we can be the solution for patients that don't have a PCP, doing some auto attribution. Also thinking about partners they've already brought, like the Blues here have brought Oshi to the market. Let's not be scared of it. Let's work with it. Let's embrace it and just stop the parallel paths, bring it together in that learning lab environment. I think, Michael, you hit upon this, right? We have primary care exists because of how the legacy fee-for-service system pays us. No one would design it from scratch. So let's lean in, get primary care right. The finances have to follow, but given our access challenges, I think we have a unique opportunity that we can do this and we'll be able to fund this and it will be financially viable.
Great stuff. Great job, all of you. Thank you to our friends at TidyCare for supporting the show and bringing us incredibly great content. Check them out at tidycare.com. Thank you to our guests. These folks all prepped with me. I'll probably prep behind the scenes as well to be prepared for today. And thank you to all of you who are listening, who are watching. We do not take the time you spend with us for granted. We hope that the ideas, the bright spots shared today inspire your thinking and enhance your organization's current approach to improving healthcare for all of us. Each week, we produce this show for all of you. Remember, this is your Bright Spots in Healthcare podcast. Take care, everyone.